It is a huge honor today to be interviewing my first dentist from Italy. How cool is that? Roberto Rossi. How bad did I butcher your name? I want to hear how an Italian says it in real life.
That's perfect.
That was perfect. All right. Well, you're too kind. And
Excellent.
you're in there's 9 dental specialties in the United States that are recognized by the American Dental Association, and I have to tell you that your specialty, periodontics, has probably changed more than any of them. I mean, when I got out of school 28 years ago, it was just all surgery, quadrant surgery, and they were trying to do everything to save these 3-rooted maxillary teeth, and now um, it's just gone into implantology. Would you say that a periodontist is now an implantologist?
Well, I would say I agree with you that periodontics has changed a lot in these past 20 years. And actually, the periodontist is probably the finest person to place implants because it has attention to the soft tissues, to the papilla, and to cosmetics, of course.
Um, that is true. Oral surgeons get blamed that they put the implant where the bone is, so they're kind of blamed for being a bottom-up implantologist.
Right.
And the person restoring it thinks it's crown down, that you start with where the crown has to be, and are you going to cement or retain screw this? And then you're addressing probably the #1 complaint of all anterior aesthetics with implants is what is the gum tissue going to look like around these implants? Is there going to be dark spaces? Is there going to be gaps? That's very, very hard.
Well, implantology has changed a lot because if we look at the early works of Brånemark, uh, nobody really paid attention to aesthetics. So implant dentistry evolved into cosmetic and aesthetic restoration. So the way we do it now is very different from the way it was done 20 years ago. And probably what's going to be in the next 10 years, we do again.
Well, how long have you been doing it? You got out in '92 and it's 2015.
I'm sorry?
How long have you been doing this? Since
Oh,
1992?
25 years, yes.
25
25.
years. So tell me how it's changed in your life.
Well, in my life, it's changed that honestly, in the beginning, we were just doing it as it was done in the beginning with little technology, with the knowledge of the anatomy, but without all the evolution of technology that we have nowadays with cone beams, with the implant navigation system. We can actually see, navigate through the human anatomy and put implants safely and in the best prosthetic position, knowing already where the soft tissue, the bone crest, the abutment are going to be. So it's a big evolution, but it's the same thing. If we think 25 years ago, we only had fax. We couldn't even dream of having a conference call from Italy to California or to Arizona. So it's the same thing for everything else in the world.
So how many dentists are in Italy?
Oh, we have so many dentists, just like in everywhere in the world.
But
We have
how
about,
many would you say?
I would say about 500,000.
500,000 in Italy?
Absolutely.
You're probably talking all of Europe because there's only 150,000 dentists in the United States. I think it's 50,000 in Italy.
50,000, maybe 50,000.
50,000. What I'm trying
Yeah.
to get out is out of those 50,000 dentists in Italy, which is the number I hear how many there are, what percent of them place implants themselves?
Oh, nowadays probably 75%.
Okay, 75%, and that's the same number we hear in Germany and in Korea. Why do you think in the United States only periodontists like yourself and oral surgeons place 90% of implants, and the general dentists in America probably only 5% have ever placed one implant in their life, and you're talking to mostly general dentists in America right now?
Well, probably because of the issues with the lawsuits in the United States, so insurance issues, and it is more risky to place implants in the United States because patients are more willing to sue the dentist, and if there is any problem, to go to the lawyer right away. In Europe, actually, it's not like that. I mean, things are changing also, but the general dentist can place the easy implants, and the companies help the dentists to become more and more aggressive, showing certain procedures are easy to perform and they're predictable. So everybody got kind of invited to place implants.
Um, so the CBCT, there's a big controversy around the United States where if you're an oral surgeon and you've placed 10,000 dental implants, the majority of them do not like surgical guides. They say, hey, you need to be a surgeon. You don't need a surgical guide. You need to learn how to lay a flap, see the bone, place the implant, and doing it, just snapping on a surgical guide and placing a drill bit through a hole, that's not a surgeon, and it works fine when everything works fine. But if you have any problem, you're not a surgeon until you learn how to lay a flap. So I'm going to ask you, because who you're really talking to right now is probably 5 to 6,000 general dentists, probably 80% of the United States, and they're thinking about placing their first implant. So my question to you is address the biggest controversy. Would you recommend that they use a surgical guide? Or and again, I'm sorry, I need to preface this question. In the United States, 95% of crowns and implants are done one at a time to replace one missing tooth. Only 5% are
Okay.
quadrant full mouth dentistry. So we're talking about missing a first molar. So you would
Okay.
have a second bicuspid in front of it. You would have a second molar behind it. So you have mesial distal landmarks. If you laid a full thickness flap, you'd have buccal lingual landmarks. So my question to you is, for that first implant that this person's listening to on their way to work today, would you go surgical guide, or would you say, no, man, suck it up, buttercup, and become a surgeon, learn how to lay a flap?
That's cool. Honestly, I teach in dental school and I teach to private courses. And I would say that, as always, the real thing is in between the lines. Uh, I would say that if you're starting to place implants, the best thing to do is follow protocols. So if you don't know about the anatomy, you don't know how to approach the crest of the bone, it's always best in the beginning to open a flap because you want to make sure that you have the bone underneath. Even if you have maybe a cone beam or CT scan, and you can read the anatomy previously. Otherwise, if you already a little bit of experience, nowadays I think it's much less traumatic to do an implant flapless. So if we have the knowledge of the anatomy and we know where we're going to go, it's much, much easier to place an implant within 5 minutes with a stent and in a very safe way.
Well, I think you're very, very smart, because one red flag of a person is not intelligent is they're always an extremist. And every great historian would always says moderation, moderation, moderation. And you just nailed it, buddy. You said the truth is in the middle. All surgical guides, no surgical guides, that's not real. The truth is in the middle. And I also think it's very interesting that you came at it with an answer first from the patient's point of view. And the patient's point of view is, I remember when I got my diplomat in the International Congress of Implantology way back in the day, went through the Mish Institute, and you would just lay these monster flaps. Unbelievable. You dissect out the mental frame and the post-operative swelling and discomfort. It was a major surgery. So to sit there and think you could just go through the tissue under ideal situations, the patient would have to love that.
Yeah, actually, in Italy, we have a way to say that is grande lembo, grande chirurgo. So big flap, big time surgeon. But actually, today is not anymore like that because the good surgeon is the very minimalistic, is the very skilled that handles the soft tissue in a very, very delicate way. So we have diagnostic means that allow us to do it in a very delicate, if not actually painless way.
The next question I want to ask you is another huge controversy for dentists all around the world. My favorite meeting in the world is actually every other year in Cologne, Germany. The big, what is it? The IDF meeting?
IDS, IDS.
IDS meeting. I'm sorry, I said IDF. IDS meeting, and love that thing. I've lectured at it before in a booth, but my they had 145 different implant companies with a booth selling implants. So how does my whole motto with using the internet and now iTunes and YouTube and the podcasts and all this is so that no dentist will ever have to practice solo again. So right now you're talking to a dentist on a treadmill, and how is she supposed to pick? She doesn't want to own 5 systems. She wants to own one. What would your first ideal recommended implant system for a general dentist be if you were only going to buy one of those?
Well, I started with at the time Brannemark system. That was probably the oldest and the one with the largest documentation in the world.
And he
After
just
that,
passed away last month in Brazil.
well, yeah, no, Professor Brannemark died about 5, 6 months ago in Sweden, not in Brazil,
Well,
in
he was
Sweden.
living in Brazil.
Yeah. No, 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 no. He was in Sweden in his home.
Oh, when he died?
Yes, yes,
Okay,
yes.
but
He died in his home. Yeah, and basically everything that followed up after Brandemark system is companies trying to follow an idea and put some new ideas into a pot. So new design, new surfaces, new prosthetic abutments. And of course, we know that in the implant world, there are now probably 20, 30 main companies that rule the world, and then hundreds of small companies that are trying to make a product that looks like and probably also works like. But as a surgeon, I will always try to stay within the first five, six important lines that are the ones that have an history, so that I know the company is there. Although nowadays these companies are buying each other, so one company is being bought by another company. So it's a world in evolution also in that side.
so what are those? You said there's top 6. Is that what you just said? The
Well,
top.
5, 6 companies that everybody knows about. That I mean,
Go
Europe
go ahead.
has
Go ahead and name them in order of which one you would buy first.
well, Nobel Biocare for sure.
And that's the one that Brandmark started. That used to be called
Yes.
Brandmark, but now it's Noble
Used to be
Biocare.
the Brandemark system. Yeah. Then the second one for me, but I think it's nowadays the first. It's ITI Straumann.
And that's
Swiss.
Switzerland.
Yes, Swiss
ITI
company.
Straumann out of Switzerland.
Yes. Then we have all the American company, Dentsply, Astra from Sweden. I mean, BioHorizon, so many. I mean, and all of them are reasonably good. So I cannot say that one is better than the
What's
other.
the,
So
what's the Dentsply implant system these days?
Um, what do they call it? They have different lines. There is no one line, but in different countries they have different names.
I can remember back in the day when they used to have the core. What was it?
Oh,
The
Corvin. Yes, Corvin.
Corvette. Was
That's
that the
probably
one started by Jerry Nisnik?
yes, exactly. But
And
that
then
was
they bought
20.
that from Jerry
Yes,
Nisnik. And then when hit
company has changed and the name and the shapes have changed. So now it's a completely different company.
and BioHorizon was the one started by the American Carl Misch.
Right, and it went through different names. It was Biolock, no Biolock. It was Minimatic. Then it became Class Implant. Then now it's BioHorizon.
What do you think about the low cost leader Implants Direct? And
Oh,
what
there are many of those.
what
It's
do you
like
think
going.
of the Korean one, Megagen?
Oh, I know all the Korean companies because I work as a consultant for most of them, and they're all very very good companies. I would say they put a lot of attention to the research. They cooperate with a lot of universities, but their limitation is that all the universities they work with are Koreans, so they produce just local work. They're not, I mean, yet very well connected with international universities, and they're starting to open up to the world, and they're doing quite a good job because they're intelligent people and very hardworking, and they have good engineers that do good engineering on the implants.
And they so what system do you use personally, and what system are you teaching the dental students? And also, do dental students in your dental school place an implant by themselves before they graduate, or is this something only postgraduate dental students do
Uh,
studying
I
perioral surgery?
I work in the postgrad, so the students that I handle are already dentists, and yes, they can do implants in the dental school, and they do all kind of implants. So
What
depending
what
on
what percent of the dental students who graduated from your dental school this year that just graduated do you think placed an implant by themselves while they were in dental school?
Well, maybe 20%, 30% of them.
20 to 30%. And what system are you placing, and what system are they placing?
Well, they can use either Nobel or Straumann or any of the other system that we named before, yes.
Yeah. And I'm surprised you're not recommending an Italian brand. You're Italian. Isn't
No,
there
no,
a
no, no, no.
isn't there a famous
We have very good Italian companies. We have Svenen and Martina that became very popular, and nowadays they're selling all over the world. Even the United States is becoming one of the targets. So
what's the name of the Italian company?
Sweden and Martina,
Sweden and Martina. Sweden and Martina.
right?
Huh. Very good. And so you mentioned a cone beam. Same thing. What cone beam do you recommend? Are they all the same, or some easier to figure out? I remember when I got mine. My gosh, reading it was the hardest thing. But back to this individual dentist. What cone beam systems do you like?
Oh, well, actually, I don't have one because I have the radial clinic just a few floors below my office, and I send them to the radiologist to do the cone beam. Uh, all kind of the cone beams nowadays are good. There is no one that is better than the other. The last generation are all more or less to the same level, and all of them have their software that helps the dentist to really see and play with the images, 1D, 2D, 3Ds, and I wouldn't say there is one that edges the other. It's all more or less the same. I mean,
Okay.
it's
So then walk this girl's driving to work right now, and she's got about 40 minutes more to go to work. How would you recommend making a surgical guide? Is this something you would take a CBCT and you would export the file on DICOM to a lab and they would make the surgical guide, or would you recommend that she takes impressions and makes it herself? Go through your surgical guide for replacing a molar.
well, for me, doing it through an implant navigation system, it's probably the safest way because you can play with it. I can actually put the implant. I can move the implant in the 3 dimensions. I can see the kind of prosthetic abutment that I want to use, and with CAD/CAM now I can already design the final restoration at the same day that I'm doing the planning. So it's a big innovation.
It's really changed a lot. It makes me want to start eating less fatty food and live longer and see what happens in the next 25 years.
Yeah, now you have to also be very familiar with using the computer because I noticed that many of the colleagues, especially the one of the old generation, they're not very computer friendly. So it's more the young people that are really fast and they grew up with the computer. So when I work with older dentists, they always have a hard time to accept this kind of evolution. But it's there, so we have
I,
to.
I, I think the way human minds are hardwired is fear is bigger than greed. So you want the greed of learning how to place an implant, but fear is bigger. And they say that when apes and monkeys are in the jungle and they're really, really thirsty and they see water and the greed of getting a drink is huge, but they see two crocodiles sitting there and that's overwhelming. That's why when stock markets crash, the 10 biggest crashes are much, much bigger than the 10 biggest gains. So the young kids, I mean, I watch my 3-year-old granddaughter, and this has happened twice to where nobody can figure out the TV, the remote, and we're all doing it. And she just walks right over at 3 years old and figures it out because she has no fear. So these young kids, I got out of dental school in '87, and we didn't have computers. And in
Right.
fact, the first computer I bought was a year after my practice opened. It was an old Intel 286, and the guy told me that if I upgraded and right at the gate bought an Intel 386, it would be so powerful I'd never have to buy another computer the rest of my life. What a joke!
Good, good.
That thing's that yeah, I've had to replace those every 3 years forever. So back to this dentist placing their first one. You've talked about implant systems. You talked about CBCT. You talked about surgical guides. What is the easier, low hanging fruit cases that should be in your mix of your first 10 implants, and what would be the opposite of that? What would be like implant case where you say no, don't do that until you've done 100 or 200?
Well, probably the implants in the aesthetic zone because before, patients were not, I mean, patients without one tooth, they just wanted to have the tooth back. Now they come to the office with a magazine with a pretty lady smiling and they say, I want this. So they don't understand that it's not just the implant, it's not just the crown, it's the bone, the kind of resorption that we have, the soft tissue, the periodontal biotype, the thickness of the gingiva, the position of the gingiva. There are so many issues related to it that if you take it one step at a time and you evaluate all these factors, you may get to the end point with an excellent result. But if you cut corners and you don't take everything into consideration, you may have a bad result.
What would you like to talk about? I don't want to be leading this interview all the way with questions. What's making you passionate, and what do you think you could tell us now that people who have placed hundreds and to the periodontists and oral surgeons listening to this, what's making you passionate these days?
Well, my passion has always been aesthetics. So probably the fact that dealing with periodontally involved patients, the fact that patients have lost bone, they have lost not only the bone but the soft tissue. So they have these teeth that are moving forward, they're opening up spaces, something that is not really pretty always really challenged me to do, I mean, something that would bring the situation back to normal. And I think what I've always loved was to look at the aesthetic aspect of both periodontology and implant dentistry. And that is the daily challenge, the daily pleasure to go to the office, not only to help people, but to enjoy solving a situation and bringing it back to normal.
Now, I would be everyone's ideal patient because I don't show any teeth. So let's talk about the hardest case, a woman. I mean,
Well,
all seven of my crowns are gold because I'm a dentist and I want to last forever. I can't get an American woman to go with a gold crown for anything in the world, even though they have gold on their ear, nose, lip, belly button, ankle. They have gold on almost every body part, but I can't get them to go putty gold even on a second molar. One time I had so little clearance and it was so far back there. I have about five full gold crowns on upper second molars on women who don't even know it because I'm just like I can't do this and she doesn't get it and I put it in there and if she ever figures it out I'll redo it for free and I still see them on 6-month recalls and I always grin from ear to ear because I got this beautiful gold crown on a maxillary second molar and she doesn't even know it. But let's talk about that case where you got that woman. I've read that women have 27% less muscle mass than men, so their lips go up higher. They show teeth and gums. So let's talk about that girl who has an upper incisor tooth. She lost it, and you got to go to implant. And so, how do you handle the tissue on something like that?
well, the gummy smile is the challenge of the periodontist and the dentist because anything that is seen so is okay, but something that is seen big time, it becomes, you have to be as delicate as possible to make it invisible. So when you have a patient like that, the first thing to do is to make sure, the way I do it right nowadays is that I build the frame. And then once the frame is built, I put the painting into it. So I pay attention to have the bone and the soft tissue exactly the way they're supposed to be. And the last thing I think about is the implant. The implants come in a second time. So I do my regenerative procedure, the ridge preservation, the ridge augmentation with the bone graft, the membrane, the connective tissue graft, anything that is necessary to reset the situation. And then I go into the navigation system. So I study and I plan my case in the computer because I want to see before I go into the surgical phase that the tooth will come out with the correct emergence profile, with the proper crestal position. And then I just do my guided implant surgery and I place a temporary crown that is designed by the computer or by the technician to have the proper anatomy for that specific situation. That's it.
So let's
Then
go.
the soft tissue are conditioned, we move on with the final restoration.
So let's go through your bone grafting procedure. So let's take a hypothetical woman. She's pretty. She's got a high lip line, and she has to remove number 8 because she had a root canal buildup in crown and it's fractured. So
Okay.
when you remove that number 8 crown on the tooth, had a root canal, maybe a post fractured. How do you bone graft? You don't pull the tooth and place an implant the same day. Is
Well,
that what you're saying?
no, no, no. Well, the assessment is very important. One of the key factors is to do a previous assessment of the situation because there is a recent publication that I like to quote when I do my lectures. There was this study that was in Brazil that evaluated the thickness of the buccal plate at 3 millimeter, 5 millimeter, 7 millimeter from the bone crest. And on 250 patients, the very scary finding was that below the bone crest, 50% of these patients had bone crest that was less than half a millimeter thick. So we cannot put an immediate implant on the bone crest that is less than half a millimeter thick. So in this kind of situation, we need to do a bone graft, which we call nowadays ridge preservation technique. We cover the graft with a membrane, resorbable membrane, and possibly connective tissue graft. And sometimes we do just a connective tissue punch from the palate that we stitch there with micro sutures with a microscope so that everything is covered and we heal and eventually. Then 6, 7 months later, we reevaluate the situation. We do a new cone beam, and if we are ready, we have the bone, we have the soft tissue, we move on with the implant.
Okay, so let's name names. You said you use a resorbable membrane.
Yes.
What do you use?
Well, I work with an Italian company. In this case, I use everything Italian because I use biomaterials that are made in Italy. They're collagenated bone graft material of porcine origin that seems to work just great. The only problem is that they're not available in the United States. So
Well,
I can
they are if the dentist emails you and you just ship it directly to his house. Trust me,
well,
trust me.
well, well,
Nothing. The customs in the United States, they could never find a bone grafting material. But I
no.
say that tongue in cheek. But let me ask you this question. What about harvesting the patient's own bone for bone grafting? I mean, I know dentists who will go back in the wisdom tooth area and lay a flap to pull a wisdom tooth, and then take a truffinating burr and pull out a plug there. And also, have you seen the new Megagen grinder where you take the extracted tooth, throw it in there, and it pulverizes it instantly to about 3 times? What do you think of that?
No, 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 absolutely. I think
Do you think that's a
the
good idea, or do you think those are bad
the
ideas?
gold standard in bone grafting is always autogenous bone. So anytime we have the chance to collect bone from the own patient is always good. The problem, as you know, is probably the quantity. Sometimes we need to harvest a large quantity of bone. If you do a sinus lift, you don't want to take all the from the ramus and have to put it in the sinus. So the use of a biomaterial is helping the dentist to make the procedure less morbid for the patient because the patient has to heal in only one side. So anytime we can collect bone from the patient himself, perfect.
But on that Megagen tooth pulverizer, a tooth is not bone. But do you think a tooth is a acceptable bone grafting substitute, or would you say you don't think so?
I wouldn't do it.
You wouldn't do it.
It's a different substance. I mean, as a periodontist, when I aim for regeneration, if I graft bone, I want to find bone. That is a big issue in the periodontal world because among the many biomaterials, we have biomaterials that are biomimetic, so they act like original bone and actually they transform into bone. But we have many biomaterials that are just fillers. So we put them there, they integrate in the area where we place them, but they're still there. If you go back 5 years, 10 years, 15 years after, you still find the particles of this product. So from the periodontal point of view, I like to do regeneration. For me, regeneration I studied in school was new bone, new connective tissue attachment, new cementum, and new, new everything. So something alive. And I don't like to use something that is just fibrous encapsulated or integrated into a situation, but is not live and available for me.
I want to say one thing to the kids listener. We have a ton of dental students that listen to these podcasts. I'm 52 years old. How old are you, Roberto?
52, same.
We're the same age, and how come you look so damn
Yes.
much better than me?
Oh, it's okay.
I must
You
be
look great.
maybe I should start eating more Italian food.
Sure.
But a lot of times young dentists ask me, what are your major regrets? And my major regrets are jumping on things new. I'd ask you that question about the Megagen. It sounds like you and I are going to sit there and take a pass on it and let the young kids jump on this, and we'll talk about it 5 years from now when you got some research. I mean, I got out of school in '87, and the cosmetic dentists were telling me to do these all Dicor crowns and cement them with Duralon. I mean, there's a difference between bleeding edge and leading edge. And by the time you're 52, especially guys like me who stand behind everything I do in my office and I'll warranty everything for free. So when I try something and the
There's no,
Targus comes off the Vectorus or the Dicor breaks or this or that or whatever, I'm going to eat these things for free. And so at 52 years old, when I see those things, I always say, oh, that is so cool. Why don't you try it? Why don't
right.
you study it and come
I
back
pretty
and
much,
talk to me in 5 years?
I pretty much agree with you because I always do things after other people have assessed that they work.
Oh my God. If you want to make money, I mean, because think about this in your line. Let's say you do 10 full mouth rehabs that are $50,000 a piece, and two of them fail, and you got to redo it for free. Or let's just say one of them failed. That $50,000, well, that's not just another case. Of those $50,000 rehabs, you might have only made 20,000 on each one. So
Right.
when a $50,000 rehab fails, that's one loss, and then you had the profits of another two or three cases. So you would have been better off just doing 6 cases that worked. And the one
Exactly.
the one thing you want to do in dentistry is you want to diagnose and treatment plan aggressively enough so that it's going to last 5 to 10 years minimum, so you can warranty it. And
Right.
and and to do that, you got to be more conservative. And those young kids, I love their passion. It's like when my granddaughter comes over. I mean, she runs around like a tornado. I wish I had a fraction of that energy. I mean, it looks like she's hopped up on some drug or something. And those young kids are all passionate. They want to dive on everything and just like, whoa, slow down. I mean, there's 2 million dentists in the world. I don't even know how many dental schools are in the world. There's 56 in the United States. How many are? Do you know how many there are in Europe?
Oh,
There's got to be a
many,
hundred.
many, many,
Yeah,
many.
yeah. So let those guys look at all that stuff and come back. I want to ask you. You're a periodontist. I want to ask you some other questions. And by the way, when I'm asking these questions, it's not so much that they're my questions. I'm trying to predict and estimate what a broad spectrum of 5,000 listeners of different ages all trying to get. But um, a lot of them wonder, okay, well, if this tooth is coming out from periodontal disease, those bugs are there. I mean, you're a human, Roberto. You weren't born with P. gingivalis in your mouth. You picked it up somewhere. It's got to be a contagious bug. And if
Right.
this bug caused a tooth to fall out, now you're sticking an implant in there. And is that going to be the same cause of peri-implantitis? Talk
Right.
about that.
Well, I want to tell you a funny story when we start this topic because I had a patient that was probably the second or the third patient that I treated 20 years ago. And this patient had a missing number 8 in the United States, and he lost it because of periodontal disease. So it was not just placing the implant, but was doing a bone graft and placing the implant with the concept of 1992, 1993 that the implant had to be palatally placed. So I placed my implant, and the patient, who was a businessman, disappeared for a number of years. He came back about 15 years after and said, well, after 15 years, I think your implant is failing, so we have to take a look at it. Okay, said, come back to the office. I took an x-ray, and the implant was perfect. The bone crest that was regenerated was there, same level of 20 years before. The tooth beside it, periodontal disease, and was dangling. It was not the implant, it was the other tooth, the other central tooth. So The very strange thing, what you said, is you take an implant, you take a tooth out and you put an implant in a patient with periodontal disease. I agree with you. We shouldn't do that. We should first always assess periodontal disease. So if somebody loses teeth because of periodontal disease, you first have to do causal therapy. Antibiotics, full mouth disinfection is what we do these days. And once the periodontal disease is completely under control, then it begins a new life for this patient, so you can start placing the implants. So the situations are so different. For me, every patient is a different island, so we cannot generalize the concept. Because this guy had a tooth beside an implant, the implant was not affected at all, but the teeth were going everywhere. So the bacteria were bad for the teeth, but were not bad for the implant. So in other situations, we have no teeth anymore, just implants, and we see peri-implantitis. How do you explain that?
How do you explain it?
Well, we know a little bit about it. We know that the bacterial flora changes from mixed aerobial and anaerobial to completely aerobial in the moment we extract all the teeth. So when we have fully edentulous patients, we have a completely different situation in mixed dentition and when the teeth are still there. But we have to pay attention to the soft tissue. The soft tissue becomes the issue in patients that are fully edentulous. So we cannot just place the implants where the bone is, but we have to place the implant at the proper position and with the soft tissue all around it. Because we know from the recent studies that everything starts with mucositis. So gingivitis, the gingivitis, which is the mucositis on the implant, is what leads to periodontal disease, to peri-implant disease. So peri-implantitis is becoming a big problem. But simply because many of the implants that have been placed without paying attention to the soft tissues.
So you said something very interesting that if you have dentition, if you have teeth, then your mouth has aerobic and anaerobic bacteria, those that live in
Right,
oxygen and those that don't
right,
live in
right,
oxygen. But once
right,
you've pulled out all the teeth, you no longer have an anaerobic environment, so you only have aerobic bacteria. So
right.
does that explain much difference in success rate of fully edentulous implant cases versus mixed dentition implant cases?
Right, absolutely. But the fact is also that we never take into account that, for instance, in patients with no teeth anymore, we can place implants and we can still have peri-implant disease, sometimes because of immunitary deficiencies, because nobody talks about the way periodontal disease works. Sometimes it's just a bacterial infection, but sometimes it's not a bacterial infection. It's the body that does not know how to defend from normal bacteria because of immunitary deficiencies. So
Well, that
we
we don't have that in America because we get all of our nutrition from McDonald's. So we get all of our vitamins in our French
right,
fries and ketchup
right,
and Coca
right,
Cola.
right. But sometimes we lose focus on diagnosis, which is a very important thing. So for me, when I see a young patient in the late 30s with severe periodontal disease, my first question is, what happened in your life in the past 5, 6 years? You will have an answer that she got divorced, the father or the mother died, or she had somebody, there was a trauma in her life. Because a patient that young with that much of periodontal disease can only be that either she had the wrong bacteria, that can be, otherwise it was just the immunitary system that did not work. And for a period of time just turned off completely and the body was just left alone against normal bacteria that became pathological.
Roberto, I'm going to ask you: were you born with P. gingivalis?
Absolutely.
But do you think you were born with it, or do you think you picked it up after you were born? Do you think you had that bug inside your mother's when you were inside your mother's womb?
No, no, that is not the fact because we are born without teeth, so we get the bacteria in the mouth after we are born. But when I was a student, we were doing DNA probing on the periodontal bacteria. We were putting the paper points into the sulcus and sending them to Sweden or to the university that were doing the bacterial evaluation. One day, one of my friends from Sweden told me, how many strain of bacteria do we have in the mouth? How many do we have?
I'm guessing 350.
Okay. If you look into a sample, how many bacteria do you think you're going to find?
In just one sample?
Well, you sample like pockets in one mouth in three, four
You mean
sites.
how many different species or how many total?
No, no. How many different kinds of PG,
I
Pseudomonas, Staphylococcus, everything.
I would say 350.
Right. So if you do a sampling, you will find them all because they're there. So I mean, the thing that they exist doesn't mean that they are pathological. They become pathological in the moment that they grow and in a certain site they develop something. So if you're looking for the Actinobacillus, Actinomycetum comitam, that now has a new name, you'll find it because it's there. Maybe it's one, two, or three, or 3,000, but you will find it there. So it's not the issues. The issue is that we should make the diagnosis early enough to prevent this bacterial infection to spread in the mouth.
I think this is going to be the most exciting breakthroughs over the next 10 to 20 years because the most famous zoo in the United States is called the San Diego Zoo, and it has 4,500 species of animals on display. And they're saying from the mouth all the way through the digestive, all the way out the back door, that 30 foot of intestine has about 12,000 species. So it has three times more animals on display, bacteria, fungi, virus in the San Diego Zoo. And there are some people around the world that even think your digestive gut bacteria is affecting your mouth bacteria. So if someone was eating the wrong foods or different foods and had a different different bacterial gut microbiome, that could even affect their mouth. I want to ask you one more question on that antibiotic, then we'll get off it. When you're preparing someone, when you're trying to get rid of or control someone's periodontal disease, you mentioned the word antibiotic. What antibiotic do you use? And a lot of questions we get is there's a lot of companies that sell like little chips of dense antibiotics that they put into the pocket.
Right.
Do you like systemic antibiotics? And if so, which one? And do you ever use localized perio chips or Arrestin or anything like that at the site? Can you talk about that?
Well, we grew up, when I was a student, Harvard University was doing with Ray Williams most of the basic study on the use of tetracycline cords that at that time were placed in the pockets that were actually having periodontal problems. Well, now we know that the antibiotic help to control the periodontal disease in the early stage, I mean, when we make diagnosis. So we need the antibiotics because the bacteria are on the root surfaces with calculus, but they spread in the soft tissues. So the bacterial control of the infection with antibiotic is important also for implants, not because on the normal patient with no issues, probably not, but in the periodontally involved patient, that becomes very important. So all the antibiotics that we know from amoxicillin, tetracycline, metronidazole, they're all in a way working towards sterilizing the situations.
So if you're placing an implant on someone who has had periodontal disease and is now under control, when you place the implant on that person who 3 months ago had periodontal disease and you were doing your protocol, would you prescribe antibiotics at the time of implant placement?
Absolutely. Although certain studies show that there is no effect. I mean, if the patient is sterilized, so there is no more periodontal diseases, there is no infection active at the moment, there is no benefit or damage to give the antibiotic to the patient.
But you still do it anyway. You still do it.
It doesn't hurt.
And back to those chips. Not for an implant, but if someone when you're getting someone's periodontal under control, do you ever use a tetracycline cord or a perio chip or an Arestin? Do you ever
I
use?
I still find the use of tetracycline very useful in patients with aggressive periodontitis.
In the
Even if
cord or chip?
even if the modern trends are slightly different, I still find well. When I studied in Boston in my postgraduate training, we were using a lot of tetracycline in aggressive. At the time was juvenile periodontitis and rapidly progressive periodontitis were treated quite well with the use of tetracycline. So, especially in Europe, the tetracycline have not been used recently. They're quite effective because the bacteria don't know tetracycline. So, it's still a very good antibiotic for me.
But are you talking about systemically, like tetracycline, like 250 milligrams 4 times a
Yes,
day?
yes,
But
yes,
but
yes,
do you
absolutely.
also ever place it locally in chips or
Yes,
cord?
yes. No, I just put it. I just take the tetracycline capsule and I just mix it with the bone graft, for instance. So I enhance the use of tetracycline has many good effects. Also, I use it a lot in mucogingival surgery, for instance, because tetracycline is an antibiotic, so it has an antibiotic localized effect on the root surface. We know that we can find the bacteria into the dentinal tubules. So the tetracycline can penetrate the dentinal tubules. It's also an acid, so it has an acidic effect on the root surface and also an etching effect on the root surface if you put connective tissue graft or whatever you're going to put on top of the root surface. So many different effects. And also from the histocompatibility of the tissue after use of tetracycline get better. So we have
And
many
and
different
and
effects.
and when this person's healing up, do you also recommend any mouthwashes? Do you think those like Listerine or chlorine
Yes,
dioxide?
yes. Well, mostly we use chlorhexidine 0.2 or 0.12%, depending on the necessity.
So you still like chlorhexidine gluconate
Yes,
0.12%?
we have no alternative to chlorhexidine yet.
So that would be the
So
gold standard.
yes,
Is it
yes, I would say.
is it called Paradex over in Italy?
Well, we have different names. Can be Corso-Deal, can be
Okay, then
Paradigm.
I want to ask you a kind of a strange question, but we're doctors, it's got to be true. If this person's healing up from periodontal disease and you've cleaned her up, you pulled teeth, you're doing all this stuff, but she's going home at night and she's sleeping with her husband, and he's got a full mouth of perio and he hasn't seen a dentist in 10 years.
Okay.
If she's kissing him, is that giving her more bacterial load and making the problem harder?
Well, that could be because there is always a bacterial transmission. We see in periodontal patients that have localized periodontitis that sometimes it starts on the lower molar, and you will see the same effect on the upper molar because there is a bacterial exchange through chewing the food. So it could be. It's not necessarily happening because it should be a long lasting. I mean, unless they kiss for 3 hours, it should not.
Look at the other end of the body. Humans transmit STDs so quick
No,
and
no, no.
fast and efficient.
I agree.
They're saying hepatitis B. You only need one
Yes.
virus for a successful infection. Whereas like the number one cause of death on the planet is drinking dirty water, cholera, which kills about 4 million people a year, and that's you need to drink 100,000 cholera bacteria because the stomach's going to dump acid, and it takes 100,000 for one to survive. But I don't know. It seems like we're going to know a lot more about this in five,
Right.
10, 20 years. A lot
Right.
more.
We should actually do a study on that. That would be an interesting thing to.
I think that the STD that no one ever talks about is the kissing.
Yes.
Everybody around the world talks about below the waist, and I think that comes from, that's the most important thing of a species to reproduce, have offspring. So they're always talking about STDs, but people are putting on a condom below their belt, and then they're sticking their tongue in someone's mouth, and we see an increase of oral cancer with HPV virus. And
Yes.
so now, I mean, I think one of the biggest stories no one's talking about is there's an STD going around called HPV, and people are
Right.
killing each other by kissing,
Right.
and
It's true.
no one's
It's
talking
true.
about this. Um,
The Italian Dental Association has done a cancer day in the past 2 or 3 years, and they do free screening in the streets. in the main cities because they're aware of these
I
problems.
want to ask you another controversial question. This is one of the biggest controversies about implantology on Dental Town. We had to separate under implantology regular root form implants and everything else from minis because it seems like um, people like yourself, periodontists or oral surgeons in America, you send in someone and they only have one solution, and it's the big Ferrari. It's the 50,000. It's 6 implants, upper, lower, sinus lifts. It's always a big deal. And in our country of America, with 330 million people, 80% of the population can't afford anything close to that. And
Yeah.
so then if a dentist goes in there and uses a mini implant, like 3M has an MTech, and they put 4 minis in front of the metal frame, and we're just talking about fully edentulous. There's 31
Yes.
million Americans. We're
Yes.
not talking
Yes.
about for a single tooth. And if they put 4 minis in front of the metal frame and 6 minis on the upper in front of the sinuses and really help stabilize 70-year-old poor grandma's denture. Grandma really likes it, but man, you just can't get any respect from your dental colleagues. I mean, all the periodontists and oral surgeons are beating their chest saying that's not even. I mean, it's almost like you're not a real doctor if you place many implants. So my
I,
question to you is, if a poor Italian grandmother came into your office clutching a rosary and she said, "I can't afford, the deluxe Ferrari." Do you
why?
offer a low cost mini implant solution, or do you do those, or do you not?
Yeah, why not?
So
I mean, I think,
you place minis?
of course, I've done many in the past, less now, but with good results. The only problem with mini implants is that they're not coded because anything that is below 3 millimeter is not considered an implant. So all the implants that were smaller than 3 millimeter diameter, I think FDA didn't categorize them like implant. Then the mini implant came back. So even in Europe is the same thing. I remember that until 1995, 1996, we had 2.9 millimeter implants on the market that they were then eliminated, and then they were brought back with that zero point 0.1 millimeter. They became 3 millimeter implants. So, but
So you're saying in the Italian Dental Association, an implant has to be 3 millimeters,
no, no, no,
or you're
it's
saying
not
it's not coded that?
because we can see also nails. Some dentists in Italy they put I mean nail needles. I mean there is a school here in Genova. One of the oldest Italian implantologists used to use nails that put the solder in the mouth and then join them with titanium bars and then place a denture on top of it. And we have examples that have been in the mouth for maybe 40, 50 years. So actually everything works. For me, it's a different concept. I wouldn't do to my patient something that I wouldn't do on myself. So if I had the necessity to put one lower incisor and I have a narrow space and the only solution is to put a 3 millimeter implants, I would do it.
So I want to ask you. There's one of the most famous dentists in the world, Gordon Christian, is saying that he thinks a lot of perio-implantitis could be an allergy to the metal, a metal allergy. And he's talking about we've all seen the phenomena where if you put on a solid noble metal, gold, silver, palladium ring, there's no tattooing. But if you use a base metal ring, you can see how the acid in the skin leaches out the metal, and you get a greenish tattooing around there. And he's thinking, and there's some websites on this. Do you think metal allergy is an issue with titanium implants?
It could be. It could be because we did some studies and was done maybe 10 years ago. And we were evaluating the soft tissue reaction to different metals on the implants. And of course, titanium was the gold standard. Titanium and gold was also pretty good. But titanium and certain kind of metals was a mess. We would find inflammation in the soft tissue just because of the um, biochemical connection of two different metals. So that's absolutely an issue. I would say, I cannot say for sure that it's the issue, but we have to look into that for sure.
So I've only got you for 5 more minutes, and so I feel like I'm not smart enough to be asking you the questions. You're so much more gifted on all things periodontal implantology than myself. What can you tell my elite listener, to the periodontists and oral surgeons, or people who are our age at 52? What do you what tell them something they don't know?
Well, I think at our age is very different to tell something you don't know. I mean, it's more the thing that would motivate people in our age is to have fun working, to do it enjoying what you're doing. Because I think the most exciting thing for me is to go to the office in the morning. I enjoy doing that because when I see my patients smiling, that's already paying off beside what I find in the box at the end of the day. So enjoying what you do and uh, being happy, making people smile, I think is the issue. If you do something that you enjoy, going to work is not hard at all.
Oh my gosh, well said. I feel like I have never traded time for money in my life. My dad had a restaurant, so I worked with my dad, who was my idol and hero, from 10 to 20, and then I worked for myself, and I've just been playing my entire career. I mean, I just don't do anything I don't like. When a dentist tells me he hates endo, I say they're called
Right.
endodontists. Quit doing them.
Right. Hmm.
Just do what you love and have
Right.
fun. And if you love it, you'll do a lot of it, which then you'll get good at it, and then you'll make money at it.
Right, exactly. Because you become good if you do it over and over and over, and you see how you can change the thing to make it get better and better from time to time. And I mean, it's the 10,000 hours rule, you know. And to become a superstar, you need 10,000 hours of practice, and to do it for a long period of time and to see it over and over again.
I've been to your country several times, and it has got to be the most gorgeous country in the world. I mean, Italy is just amazing. And I'm not saying that because I was raised Irish Catholic and my oldest sister is a nun. I mean, I just truly love Italy. I mean, it's just the most amazing food. But since 80% of my listeners are from the United States, and a lot of them have never, or if they've gone to Italy, they've gone to Rome, they've gone to all the tourist places, they didn't go visit a dental office and understand the systems. Tell us, what differences do you think American dentists don't realize with doing dentistry in Italy? Like, do you guys use insurance? Is it paid for by the federal government, or is it private insurance? Or are you allowed to advertise like we do in the states? Or tell us those types of issues. What's
The
different about
Italian
Italy versus the
world
United
has
States?
changed completely. Until about 7, 8 years ago, you could not do any kind of advertisement. It was very severely checked by the dental association, and basically dentistry in Italy is just private practices because the hospitals provide a dental system that is very weak. Very few dentists work for the hospital, and the insurance company very rarely pay for dentistry. So only people working for big companies, they may have a small insurance company that covers part of the cost. So people going to the dentist, they have to pay with their own savings. So
And
that's the
do you think that makes Italians use the dentist more or less than America, where 50% of the people have some form of insurance? Do you think it's a
well.
factor or just not really?
No, no, no. The people before the bad economy, they love to come to the dentist because they want to eat well. The food is good in Italy, so people like eating and they enjoy chewing the food. So they need to have good teeth to enjoy what they're eating. One of the issues with the patient is very often I want to have the denture away because I cannot feel and cannot taste the flavor of the food. So that's one of the common chief complaint. So I understand that. If I had a piece of plastic in my mouth, I'm sure that it tastes different than if I have my natural dentition and something that can handle the chewing in a different way. But we have a lot of low-cost dental clinics popping out in Italy because the multinational discovered that dentistry is a business, and we have low-cost dental clinics coming out of nowhere everywhere. In every city in Italy, there are now 5, 6, 10, and they're bringing down the level of dentistry that I think in Italy is very, very high. We have excellent dentistry in Italy, and even if the dental schools are not all fantastic, but the level of preparation of the Italian dentists, I think, is pretty high.
So you're a member of the EU, Italy is. Now, are
Yes.
you able, Roberto, to take your Italian dental license and go practice in any other EU country, or are
Yes,
there you can?
absolutely.
You can all
Absolutely.
move around.
Yes, absolutely. If I
So
want to go to work in France, in Germany, and no problem. Yes, I
so if
just
you
have to notify the local organization that I'm going to open a clinic there.
so you're saying that because of Italy's joining the EU, it's allowed an influx of licensed dentists from other countries into Italy. So now there's more dentists on every corner. Did I hear that right?
No, not really that. I mean, we have only some, well, some German, some French neighboring countries can, like we go to Germany, they come to Italy and they practice here now. But it's a different phenomenon. The low-cost dental clinic appeared in Italy, something that never happened before. I mean, before the dentist was the dentist. Now the dental clinic that offers the cleaning for 20 euro and the free consultation, free X-rays, it's something very, very new that is entering the Italian system and is bothering a lot of people.
So we're exactly at 1 hour and it's over. So I want to ask you a question I shouldn't have the right to ask you. And if you don't like the question, I can chop this off at 1 hour. But I'm just curious. My oldest sister is a Catholic nun. I'm just curious. Are you Catholic? And what do you think of
Yes.
the new Pope?
Oh, I love him. The moment I saw him, I fell in love with him.
My God,
Very
he's
nice.
a rock star, isn't he?
He's a very nice guy.
I
He's a
just
very nice guy, and he's cleaning the house. So uh, I know a lot of people in Rome don't like him, but he's the right person in the right place now.
My God, I never saw that coming. I never thought I would one day be cheering on the Pope. I mean, I just, I mean,
No,
it's just,
the best Pope the world could have at this time in history.
and can I put words in his mouth? I just think that the fact that he doesn't take a limousine and he takes, he drives his own small humble car and he's just a humble guy. I think he would be telling Dennis. I'm putting words in his mouth. I think he'd be telling Dennis to say, "Hey, if they can't buy the big rich Italian Ferrari full mouth $50,000 euro implant case, check out those minis." I mean, something's better than nothing, and I just don't know why dentists only sell Ferraris and Audis and Mercedes
No,
Benz. I
that,
just don't know
that is
why.
wrong. That is wrong. You should always find the right car for the person that you have in front. So not necessarily everybody, not all our patients have the financial capability and the necessity to drive a Ferrari. Some people will be very happy off with a 500. So I mean,
What's your personal favorite Italian car?
ah, oh, that's very hard to say because I was just driving a week ago a Ferrari because I took my to Maranello to see the Ferrari Museum and we had a ride in Ferrari, California. But I would say I like the new 500. It's very nice. It's a car that is selling very well all over the world. Is charming, is small,
What's
is
it called?
comfortable.
What's it called?
The 500, the small, the tiny, the what used to be the 500. It's called 500.
And spell it.
500.
Okay.
500.
Oh, okay, okay.
Yeah.
Very
That's
good.
the old,
And I just want to say one thing to all the Americans who haven't traveled around the world because they're too young or they have too many student loans. But when you eat Mexican food in America, it tastes nothing like any food. You can't even find any of those dishes in Mexico. When you go to China, you can't find a single Chinese restaurant dish in America in China. They don't even know what you're set. They don't even know what you mean when you say chicken, almond chicken, or sweet and
right.
sour pork or whatever. But I'll tell you what, I thought Italian food would be the same in Italy as it is at the finest Italian restaurants. And my God, it was so much better. It was just, I mean, I'll never forget in Venice eating, oh my gosh. I mean, it's just that food. Your food is at a different level. And you tell any of those Italian restaurant owners in Italy that they could make bank moving a real Italian restaurant to any major city in America, because you go to the nicest Italian restaurant in America and you just get a nicer delivery of what Americans think Italian food is.
Right.
Americans don't know. Maybe I mean, have you ever eaten Italian food in America? I mean, New York, or have you ever found authentic Italian food in America that's as good as back home?
Yes, yes. No, when I lived in Boston, I used to go to the North End, which was the Italian section of the city, and there were good Italian restaurants there.
But that's true. But Boston is the oldest city in America. That's a 400-year-old city, and it's the closest major city
To
to Italy.
Europe. It's true.
But you
It's
get out
also
you get out here
hard.
to Phoenix, Arizona. I'm on the other side of America. I'm on the side closer to China, and I mean, it's literally almost comical.
Probably San Francisco because there is a big community of Genovese that left Genova for San Francisco, and there are good Italian restaurants in North Beach
And then
too.
I want to ask you one last question. We're in triple overtime. We're 4 minutes over, and like I say, I can cut this. You don't like it, but Greece is in the news 24/7. A lot of dentists over here, they don't really understand the issue. You're living there. Uh, we dentists, it's just one 600-word story every day. What is the Greece situation, and what is your prediction? Will Greece be in the Euro 10 years from now? Is this going to work, or do you think it's not going to work? Or what would you
Uh,
say to American dentists?
well, for Europe, I hope that it will work out. On the other hand, the depth of Greece towards Europe is quite big for the capability of Greece. So it will take a big turnaround from the politicians to fix everything. But it's the interest of Europe to keep Greece where it is.
Can I tell you? I have an MBA from Arizona State University. I love business, and you know what my takeaway is on the Greece issue
Hmm.
is that the euro still doesn't see themselves as the euro, and Americans see themselves as American, and we always are transferring extra money from rich states like California and Connecticut to poor states like Mississippi, Alabama, Kentucky, and
Right,
we've done it all year, every year. Since the Civil War, I mean, we always do this, and
right,
and Americans would never say to Mississippi, "Oh, well, you got to pay us back." Or
right.
we just see it as distributing wealth. We're all in this together. And the bottom line is, and I'm not over there, and I don't know half as much of this that you do, but the bottom line is, Greece is poor, 10 million people, and you're gonna have to give them debt relief, and and the richest countries over there are gonna have to be always giving money to some of the poor countries so they get their act together.
Right. I agree. I agree with you. So I hope that the richer states, Germany, Italy, France, will find a way to help Greece because Greek people are also nice people, and I have many friends there, and I feel bad for them that they're going through a
And,
quite
and the
difficult
last
period.
word, the last word's going to come from me. There is not one authentic Greek restaurant in all of Arizona. So you should go over to Greek. You should drive over there and tell them, pick up your restaurant and move to Phoenix, because you know a fat dentist in Phoenix that will eat there at least once a week and take his four boys. But hey,
Well,
I am.
visit you one day. I'll bring you some tzatziki instead of some pesto.
Hey, truly, seriously, you're a rock star. I mean, I follow you on Facebook. You have a course coming up on Dental Town. I can't wait to see it. And thank you so much for 9 hours ahead of me, spending an hour with me. And I just think the world of you. And thank you so much for your time.
It was a very fun time spending some time with you, and it was a privilege. So I can only say thank you very much.
And I love your haircut. You must be a model. Bye bye.
Thank you.